Yes.
Okay, great. Good afternoon. I want to welcome you to the Rural Health Network meeting. This is the second one in a series of 4. We have a great lineup for you today. I thought it might be a great opportunity for Melissa Jacobs to introduce herself. She's the new Libby, as we call her. The new health standards person. We all refer to the new Libby, and tell a little bit about herself. After that, we will have John Bellamy from the Park Street Health Initiative with his experience in doing CHW services and billing for CHW services with Park Street Health Initiative. And then if we have time, we're going to have Danae Hebert from the Louisiana Rural Health Association give an update from the Policy Institute. Any of you are more than welcome to give feedback, or there she is. There's Danae Hebert. Any of you are welcome to give feedback. I know several of you went to that as well. When we get to question and answers, we encourage questions and networking, and that's the whole point of all of this, is giving you guys a venue to not only hear some things, but network together. So I'm going to turn it over to Melissa Jacobs.
Welcome. Hello, everyone. I'm the new Libby, less red hair, I guess, more blonde. I'm excited to be working with everybody. Just a little bit of background about me. My name is Melissa Jacobs, but I go by Missy, so feel free to call me Melissa, Missy, either one. Sometimes it can get confusing if you email me. My email address is melissa.jacobs@la.gov. I am a registered nurse. My clinical experience was mostly med-surg. I did some telemetry, cardiac, also clinic setting as well. Most of my experience before I came here to Health Standards was actually in the Medicaid, Louisiana Medicaid world. A good portion of my years, 15 to 20 years, was with program integrity, surveillance, utilization review. And then at the state here, I was in program operations back when it used to be called that, with Louisiana Medicaid. I was a program manager for the professional services program. And any of you that might have been around, I guess, between like 2007, 2011, you might even recognize my name, because I was also involved with the RHC, FQHC piece a little bit, some other programs. And then basically I came to Health Standards about 1.5 years ago, and I have been the program manager over the Behavioral Health Services program. And then, fortunate enough, there were some shifts around here. Libby actually moved up to a supervisory role, and when her position opened, I applied for that. So I'm very lucky and blessed, actually, I should say, that Libby is still here. So I'm transitioning into a position where I have somebody that's been doing this for, I think, at least 5 years, that is going to be able to share her knowledge, just be a good guide and preceptor for me as I, transition into this role. As far as contacting me, probably the best way or easiest way is through email. Definitely you can call me as well. What I would suggest, especially in the beginning, because I am still learning, is if you email me or leave me a message, just give me a good amount of detail to what your question is, and then that way I can research it and then sound really smart when I call you back. But yeah, I'm excited to be a part of this. I was fortunate enough to meet all of you a week or so ago. I don't really have any really specific updates. I don't know if you have any questions or anything. I know the big thing, the biggest question we've gotten recently was the piece about the mobile unit. That is something that right now, I think, and most of you should know, is that if you look at the hospital regulations, any rural health clinic that is an off-site of a hospital, the hospital regulations have an update. I think it was around October, November, to where you can have a mobile unit if you are part of that, hospital offsite based. As far as packets, I'm still learning, and I come from a different world as far as with behavioral health, and the packets I've seen you all submit are actually very excellent compared to what some of the stuff I've seen in my previous role. So again, it's great to meet you. Feel free to reach out to me anytime. And I might be slow getting back to you, but I promise that I will. I'll always make sure that I will follow up. And of course, Libby is still here. She couldn't make it today, but she is my supervisor. So feel free if there's anything that, feedback, or you feel free to reach out to her as well. She's available too.
Awesome, Melissa. Thank you so much. Just to clarify, you're saying basically the type 3 RHCs, Department of a Hospital, can now do a mobile RHC. And that is as a part of an existing RHC?
Correct.
Okay.
Correct.
But not a completely independent one.
Correct. So not a complete, I think I saw that question come up. That piece is still on hold. That is something that we are still working on. So I do anticipate more information on, if you're an independent rural health clinic, some more information will come forward in the future.
Great. Did you want to clarify about the federal changes and about the hematocrit and hemoglobin and stool for occult blood? About the
I don't even know. I don't think I can even speak to that. I'm
Oh,
sorry. You probably are more at this point. You may know more than I do.
Well, the federal government changed that, so you may hear that from the clinics, but it's still in licensing regulations. So I believe the surveyors are still surveying for that in Louisiana.
Okay.
So that may be kind of a conflict that you hear of, because a lot of our clinics are tied into the national networks of information.
Right. Okay. Yeah. Thank you for that. See, I'm going to be learning things from you all as well. So thank you for that.
You're welcome. And the Bureau's here to help you as well. We've got a lot of great people on today. We're all here to support each other in rural. That's the nice thing about rural. Does anybody have any other questions? Eric, do you see anything in the chat, or Amanda?
Nope. The only question was already answered, so I think we're good.
Okay. Thank you so much, Melissa. You're more than welcome to stay on. But I'm going to introduce John Bellamy from Park Street Health Initiative.
Actually, I'm sorry, Tracy. There is one more question about potential changes to telehealth regulations.
Okay.
Ending on March 31st for RHCs. Do you have any information about that, or just Missy?
I believe, Danae, do you have any information on that? I thought that was kicked down the road.
It's complicated. So I think it depends on which telehealth regulations. So the G2025. Okay, so I think that's what that is. If I'm thinking of the correct thing, and I may have to do some research to make sure I'm giving you completely accurate information, but I think what you're referring to is RHCs would bill the one code for all the telehealth services, but they're like basically unbundling those. So you can bill that one code through, I think, March, and then you would have to bill the independent codes after that. Is that the right thing that I'm thinking of? Patty posted about it this morning. I haven't seen the post, so I'd have to look at what that is. But I know they did basically like kind of unbundle the codes. So you're billing the independent codes now rather than like the one G code for all the telehealth services. But it wouldn't be for our full rate. Yeah, I think I think NARHC has a webinar about this coding change on their website that might be helpful as well. Let me actually see if I can find a link to it, if that's the right thing, and I can just pop that in the chat while we move to John's thing so we can.
That's awesome. Thank you. And just a reminder, I'm sure NARHC in March will be talking about this. I think I saw an email from them this morning about an upcoming webinar about telemedicine specifically, but I will go back and look for that.
And also, Tracy, can you just repeat what you said about hemoglobin, hematocrit, and the stool for occult blood? I think Greg maybe missed part of that.
Okay, so nationally, CMS on National Rural Health Day said we are no longer going to require hemoglobin, hematocrit, and stool for occult blood tests in RHCs. So you will be hearing that from the national associations. You'll hear that at NARHC, things like that. However, it is still in the Louisiana licensing regulations because they updated the licensing regulations before CMS released that change. So the licensing regulations, which they are going to be working on updating, my understanding is they will adjust to that in the future. But the surveyors for Louisiana licensing may still be looking for hemoglobin, hematocrit, and stool for occult blood because it's still in the licensing regulations. So again, it's basically everybody but Louisiana. But we're going to get there. Oh, you're welcome. Any other questions? Okay, well, we'll move on to John with John Bellamy with Park Street Health Initiative. He is a community health worker. He's also one of the owners of Park Street Health Initiative and provides CHW services and is very experienced with the billing part of CHWs. That was one of the things you guys asked for on the last call. And we will focus mostly on the Medicaid side. We'll be getting more information on the Medicare side, but anybody who has more than Medicare is certainly willing to, certainly welcome to speak up when we get to the question and answer part. So I'm going to hand it over to John.
Oh, thank you, Tracy. My name is John Bellamy, and I'm the executive director for Park Street Health Initiative. And I'm also an owner of an independent rural health clinic. So I know, the obstacles that you face and the things that we do, as far as to make sure we're profitable each year. Now, it's just like raising canes. A lot of times I know everybody in the clinic is like the cashier, the cook, and everything in between. It's the same thing for the clinic. As far as right now, I know it's people probably doing cost reports and they were getting ready for their survey either this year or next year. But, we're going to talk about that now. I'm usually the person behind the camera and creating the presentations and the videos and everything else, but I'm the presenter today. And I'm going to have a little help from Sarah. That's going to be my AI that I try with this PowerPoint presentation that should go well.
Thank you, John, for the introduction. I'll go ahead and start with the first slide.
So, this is the introduction to community health workers. Some people probably not familiar with them. I know it's, I think we went to a conference probably about 3 years and Tracy had a great presentation with another person that was with her. And I was like, oh man, what is this community health workers? So, Sarah's going to tell you a little about it too.
CHWs are frontline public health workers who serve as a liaison between health services and the community. They improve access to care and enhance the quality and cultural competence of service delivery. CHWs provide outreach, education, informal counseling, social support, and advocacy.
Now, we have some billable CPT codes for everybody that's not aware of it. 98960, that's for an individual CHW service with one patient. You have 98961, that's a group CHW with 2 to 4 patients. And we're going to get into that one too. That seems like that's the best one, the 2 to 4. And then we also have 98962, group CHW services between 5 and 8 people. The maximum reimbursement, we're going to get into that. Sarah, can you bring that up?
Maximum reimbursement, 2 hours per day and 10 hours per month per enrollee CHW services are incident to the supervising physician, a PRN, or physician assistant. The supervising provider does not need to be present during service. The rendering provider for incident to services is the supervising physician. Both individual and group sessions are allowed.
And now that's a big thing when as far as the supervising provider does not have to be present during that service. So a lot of times this could be done after hours, or it could be, between a day. But a lot of times we're trying to free up that physician so she could see more patients or he could see more patients during the day. And, I feel it's a great program in trying to free up the time of the physicians and nurse practitioners for things that we think a person with a high school diploma can handle inside the clinic. Now, right here, you see the rates. This is the rates with those CBT codes that I mentioned. And you see let me move my screen over a little bit because I'm seeing everybody. I'm seeing Tracy and Danae. But the one, okay, hold on for 1 second. Okay. So you see the $18 is kind of cutting me off right now. It's $18 for the one patient. 98961, that's the one in between 2 to 4 patients. I think that's 604 to be exact. And 98962, that's $2.79. And of course, I know that these are group sessions when you mention the 2 to 8 patients at a time. So, a lot of times um, we may have siblings that have the same type of obstacles. It could be some family therapy or anything like that. You could put that group in together and also put the billing in that you actually seen 2 patients during that time. Or, some people may have more going up to 4 or 5. Right here, where I'm showing you an example of the pay range for the different 6 plans. And I'm gonna get into 2. This is visit 1, and this was with Louisiana Health Connections. This is one that we bill for frequently too. So visit 1, you see the procedure code for T1015. It's a sick visit. They came in for, I don't know, something going on with yeah, and this is flu season. We're gonna say flu season. They came in for flu, and then you found out that person actually is gonna be homeless in the next month. So the insurance is gonna pay you 120. I mean, that's the average going around if you have behavioral health involved in your RHC. So 120.69, and then you have a follow-up with the insurance paying you, of course, that community health worker that serviced that patient that day too for as far as with the shelter. So, that CHW called a couple places and then they got them in or they got on a waiting list. So instead of that $120.69, you would get the 138.80 for that CHW doing their initial work after the physician seen that patient. Now, this one is a little sweeter, and this is through Aetna Better Health. And this is an example of a reimbursement through visit 2. Now you have visit 2, that's going to be a procedure, the T1 code for 120.69, but you have the G9919 code as far as from Aetna Better Health only. And I think it's another insurance company that pays the $30 too. So you got that insurance payment of $30 additionally to that 120.69, and then you also got the follow-up of the $18 from the CHW. So that brings that visit up to 168.80 from 120.69. And this next slide, we're going to look at the CHW salaries. Now, the CHW salaries is around $40,000. And we got to find a way to recoup that salary as far as, through patient encounters and also making sure that CHW is doing a great job with the notes and everything else. But we want to recruit that salary, and we're a business. We want to make a little profit on the side of this one too. So in this next slide, I'm going to show you how to do it. Scenario 1 is CHW funded through Medicaid for 1811. And with the 1811, without that $30 from, like, say, for instance, Aetna, I think that's one of my insurance companies that we have the lowest enrollment in. Well, it would take 2,245 encounters. per week. I mean, after the 50 weeks. So that's around 45 encounters per week. Scenario two, CHW funded through Medicare, is $90 average. Now we're going to find out more information when we go to the nationals about the Medicare payment, but the average is $90 or over. You know, Medicare is different than Medicaid. The total encounters needed for that $40,000 salary would be around 452, you know, at the end. And as far as the encounters per week would be 9. So you see the difference between the Medicaid and Medicare. I will recommend for somebody in family medicine to do both, but you see the difference when you get the Medicare encounter going on. Hold on for 1 second. Okay, going back to the next one. Okay, so you see the slide, how I broke it down as far as the 18, 11, and the 90 for Medicare average. So you see the difference with the 9 and the 45. Like I said before, most likely you would do both, and you would include some group sessions in too. Group sessions is great when you're doing those 4 patients that maybe have, you know, the same type of life. Say, for instance, you did a healthy lifestyle series or something like that and did it every month. Well, the word of mouth is going to get around that, you know, as far as you're not just a doctor's office, you actually care about the patient and your empathy to their needs as far as socially. So, you know, as far as more people want to, you know, have those encounters because they know that they could talk to a community health worker inside your clinic. Takeaways. This is what me and Sarah came up with. Sarah, can you talk about the takeaways? Go back, Sarah.
Key takeaways. Relying solely on Medicaid reimbursement requires a significantly higher number of patient encounters compared to Medicare. Medicare reimbursement significantly reduces the number of encounters needed, making CHW financial sustainability more feasible. Group sessions provide additional revenue, but do not significantly impact total revenue generation. Incorporating both Medicaid and Medicare reimbursements will improve the financial success of CHWs in the clinic, ensuring long-term sustainability.
Oh, thanks, Sarah. So the benefits of the CHW services for revenue. You know, I came up with some pros. No cons involved in this, you know, as far as it's all pros that I have in there. And
CHWs help increase billable services without requiring additional provider time. CHWs can capture additional reimbursement through follow-ups and education sessions. Maximizing group services increases overall reimbursement. Improved health equity and access to care strengthen patient-provider relationships, reduced health disparities, and social determinants of health.
And the 3 that Sarah mentioned at the bottom are big as far as the improving health equality and access to care, strengthening patient-provider relationships. We know that our providers, um, they're usually seeing, you know, as far as more than the average patient loads when it comes to rural services. So a lot of times if somebody is helping that doctor out or that nurse practitioner to talk about, you know, the small things that make the difference in that patient's life, that is very needed. Expanding our roles in our office. Let me talk about what we did in our office. Our office, we actually train our receptionist, our manager as CHWs. Now, 1 out of the 3 are actually able to bill, and that person is me. That's able to bill. I actually went to LaShawn / LSU Health's class, and I didn't need the qualifying hours after I finished. Now, if you go to another program, you might need the qualifying hours of, I think it's 3,000 plus hours. But, you know, as far as I didn't think it was a loss with, you know, the 2 that went to that class because it still improved their customer service and how to, you know, manage referrals. CHWs enhance patient engagement too and reduce missed appointments. Now, a person knows, you know, John, and you know they're missing their well visit or something, and I just say, hey, you know, let's say Amanda, um, say, hey, John, I couldn't make it today. Well, let's see if you could get on tomorrow. We got an open schedule. And, as far as, we have walk-ins. And I know the kids was in school. That's a person talking to another person to reduce the business appointments. Next steps to implement, training existing staff or hiring CHWs. As far as a lot of clinics, that's what you have to do, train existing staff. I would recommend training existing staff because it's going to be the first year is going to be kind of slow. So I would want somebody that's already on my staff that I trust, that's been there for years. I wouldn't want to train them and then leave. But it's somebody there that probably could take on that additional role. Ensure proper billing and documentation. I would say put those notes in the EHR system for the CHW to do their own notes inside that system. Monitor the reimbursements to see the trend. As far as if I didn't do the extra research for Aetna, I would have not known that was $30 more just for a G code. So I recommend everybody to keep on looking up to that and expanding also those group services. Well, excuse me, group sessions. And that's the conclusion. If anybody has any questions, let me go, shoot for them. And I try to answer them to the best of my knowledge and get back to you if I don't have the answers.
Yeah, John, thanks so much. We've got a couple of questions in the chat.
Okay.
Blake wants to know, are these billable and reimbursable on the same day as your regular encounter codes or payments?
Yes, they are. As far as say the ending of it again, Eric, because I'm not looking at the chat.
Are these billable and reimbursable on the same day as your regular encounter codes or payments?
Yes, because that provider will put in their notes that they refer that patient to the CHW. And if they're in an EHR system, that community health worker respond back saying that I spoke with John Bellamy on that day per the physician's orders to talk about as far as transportation issues. And I addressed it. And that transportation issues is an example by saying that Medicaid actually covers transportations. And that person talked to that patient, and it should be the end of that note. And the provider can actually, close that out.
Great. And Selena said, are CHWs like health navigators for CCM?
Yes, they're known as different names across the country and in states. We call them different things. Navigators. I heard some other things that they call them too, but they're still primary CHWs. If they went through that training from LaShawn, that's still a CHW, but they're named different things. Yes, that is correct.
Thanks. And I think you talked about this a little bit, but just to recap, what documentation is required for each patient?
Documentation required for each patient. I know I was more technical with it, so I would have the timestamp of what I like doing it through EHR because we actually populated um as far as the actual note, so I could bring up different things and make sure I don't miss anything when I'm talking or texting, inside that note. But basically the same documentation that you would see that any provider would, you would have your own side of notes and do it the same way. And she could reach out to me. I could actually show her what we populated on our EHR, and I would do that the same as everybody else, and also have a resource guide too for that CHW to know what services is around their area in Louisiana, as far as either if it's nonprofits or just a Medicaid number and things like that. I have that all in one resource guide so we all know. But yeah, just populate it in your EHR the same way that you would do any other provider.
Okay, two more questions.
Okay.
Blake wants to know, are the salaries included in the cost report like any other employee at an RHC?
Yes, you would include that in your cost report. So say for instance, if you hire one just to be a CHW, that would go into your cost report as support staff. and you would put as a community health worker there. So yes, you would include that in your cost report.
Okay, and last question. You
Okay.
talked about conducting these encounters after hours. So would
Yeah.
you be conducting these sessions after the posted RHC hours? Are these codes billed under the RHC or under regular Medicaid and Medicare?
Those codes are billed. Since we're RHC, we've been billing them, and I will have to talk to the billing manager to make sure, but she was billing those under the RHC. And as far as that per after hours, meaning if you had to make a call, so you're not really it probably would change if it's a face-to-face encounter, and Tracy may know more about this one because it may change if it's a face-to-face encounter, because you have, you know, regulations with the RHC that you have to do certain things during hours. But if I'm making a call to a patient to keep track of an encounter that happened that day that was basically an emergency, that's what you're doing. But if it's a, you know, appointment, I don't know. Tracy, you know anything about that? Can you grab that one? That
My
one is
experience
the one.
it's been mostly during the day, during the
Okay.
hours of the RHC.
Yes.
I mean, you could certainly document, and just FYI, CHWs can operate in regular clinics as well as RHCs. We're just talking about RHC billing here today.
Oh, and Eric also include that's for all Medicaid. You know, that's not just our RHCs that can take advantage of this. This is, you know, as far as for somebody that's out there that may not be in the RHC or may be getting ready for RHC, they can actually bill for that now.
Mm-hmm.
Great, thanks so much.
Any other questions or feedback? I hope this was helpful. My intent, if you're interested, and I want to hear some feedback from you guys, is to get with Ashley Winterstrom to be able to do more on the Medicare side of the billing, because we know that's a little bit more lucrative, better reimbursement. But that's so specific. There's some intricacies of that. It's a little bit more complicated than Medicaid billing. So I thought we'd do that and possibly telemedicine on the March call at the end of March. But let me know what you guys want when we talk at the end. If there's not any other questions, I'm going to hand it over to Danae Hebert to talk about the Policy Institute and some of the policy implications that may or may not be coming. Thanks.
Hey, thanks, Tracy. So real kind of casual comments. I don't have any slides or formal presentation prepared, but I'm happy to just kind of share the conversations that we had a couple weeks ago in DC. We were there for the National Rural Health Association Rural Health Policy Institute. And so for all the Louisiana folks who were there in attendance, we scheduled meetings with the delegate offices and met with the staffers, and brought some of the concerns for the rural providers. So we spoke about pricing transparency and the good faith estimate stuff that's coming, and the challenges that I know this is RHC, so but some of you folks are hospitals, so we did speak to the pricing transparency issue for hospitals, and particularly the machine readable file. So we did educate the staffers on the burden that places on rural hospitals. And then we also spoke a lot about Medicare Advantage and the challenges there, and our asks for support in specifically really enforcing the rules that are already in place for Medicare Advantage plans, and the way that they're working not only with the patients but also with the providers, and the issues with reimbursement and the prior authorization issues, the denials, and just all of the things. Pretty much every phase of Medicare Advantage's challenges. So we spoke to that as well. And we talked about some RHC stuff. We did bring back up the RHC Burden Reduction Act that's been kind of floating around the Hill for a couple of years, and how we'd really like to see that move forward. For anyone who's not familiar, that bill, it actually includes the some of the lab stuff that CMS kind of did handle regulatory wise, but it also kind of fixes some other antiquated stuff from, you know, when the RHC program was initially set up, and including the requirements or the language around the you know, primarily engaged in primary care. So it would help fix that issue of if you're trying to not see too many mental health patients, and that might be causing some survey issues for you. So that RHC Burden Reduction Act has a lot of that fixed language in there. So we educated on that. And then we talked about, you know, protecting Medicaid and protecting from funding freezes and those sorts of things as well. So those were a lot of the conversations we had on the Hill. And coming back from that, we did follow up with additional, there was additional chatter about potential Medicaid changes. What the conversation we're hearing is there's a lot of energy around per capita caps and work requirements. So those are the two things we're kind of anticipating coming down at this point. You may have seen that I think the House did pass a resolution yesterday. I think it's with the Senate now, so that's still moving around the Hill right now. That would likely lead to some type of Medicaid cut, the way that the budget resolution is written. So there's concern around that. It doesn't specifically say that in there, but that's the concern that we have, is that will come. So we do have, NRHA has some advocacy materials around Medicaid cuts, and we have some on our website as well. If you go to lrha.org under advocacy, we do have some links there and some information. If you'd like to reach out to your representatives and say, hey, please don't cut Medicaid, you know, we need to protect it for your payer mix and that sort of thing. So those are the things we've been really pushing on at this point. And I appreciate, I think, who was the person who brought up the telehealth issue, Holly. Thank you for bringing that back up. The telehealth, it is not. So I just made a phone call to NRHA to verify that I was correct on that. So the telehealth piece would not be included in the resolution that's going around right now. That would be in an appropriations package or a continuing resolution that would happen later. So that does need to happen by March 15th. Either another CR or a budget will need to happen by then, for the timeline, because the budget runs out. The continuing resolution that they previously did will expire. So they need to do that by March 14th. So now is a good time to start reaching out, not only about the Medicaid piece, but also about the telehealth piece. So I appreciate y'all bringing that up, to make sure we put that front of mind as we work on the Medicaid thing, to also work on the telehealth. So we'll be, I did put in the two, the NRHA and the NARHC voter voice. So if you go to those links that I put into the chat, you click on them, you put in like your address. It's already got a lot of language in there for you. You can add your own language, which they encourage. And then it'll automatically figure out who your representatives and senators are and email it to them. So it's like really easy to do, to send those emails off, asking them to extend the telehealth flexibility. So, and then I'll be this afternoon adding that to our advocacy page as well. So you can go find both of those links there also. Any questions, or Tracy, anything else you can think of that you wanted me to speak to? You're muted, Tracy.
Sorry, we see some questions in the chat.
Let's see.
Eric, you want to call?
Yeah,
Yeah,
I can see the chat. So
Oh, okay.
yeah, that's just Eric responding there. What about the Medicaid telehealth piece? So the Medicaid is separate. I think that the Medicaid stuff was permanent in the, like, I don't think that that's, I think the Medicaid was made permanent. Is that right? I'd have to look at it honestly.
I have to
Because the
look at,
Medicaid rules are separate, what they pay for in terms of telehealth, and they were always different from the federal ones, from the Medicare payment rules.
and
So
of course, all of that's subject to the budget.
also, yeah. So if they're planning any changes, we don't know at this point. I haven't seen anything from Medicaid at this point, but we'll keep an eye out for that. But I'm not in the weeds of the telehealth rules as much as I once was to keep up with all the nuance of what Medicaid has been doing. But I haven't heard any changes at this point.
And again, that's what I'd like, unless you guys want something different. I thought that might be a good topic for March because we'll hear more about that. And hopefully by the end of March, we'll have some information on the continuing budget and things like that. As well as CHW Medicare billing. Does anybody have any other questions? Wellhead is going to make this available to you. This is being recorded. It is available for review. Any of your staff. We will have the next meeting at the end of March. You'll be getting information of that. Yeah, I know you signed up on the Zoom for that. And now it's just a part of getting feedback from you guys. Do you want to open it up, Amanda?
Sure, absolutely. Anyone should be able to. You guys, if you have any questions, feel free to unmute or go ahead and put it in the chat.
This is your network meeting, so we want to hear what you want, what you're interested in, what your successes are, and what your needs are. Don't forget, we're writing grants as we speak, so we need to know those needs and those plans so that we can include them and help direct the information, get you the right services that we are trying to provide from the State Office of Rural Health. Eric, do you want to talk about the email and where you want the emails to go through?
Email for what?
The PCRH. So I no longer
Oh.
have the tracy.ingram@la.gov.
I see what you're
And-
saying. Yeah.
Mhm.
Yeah. So everyone, if you have any questions about rural health clinics, you probably already have Amanda and my email address, but if not, here is kind of a generic email address that we use. I just put it in the chat. It's pcrh@la.gov. That's primary care and rural health, in case you're wondering what these random letters mean. And so that's one way that you can get in contact with us. Another thing that we have been promoting is our mock survey request form, which you can access on our website. I will also put that in the chat. So if you're interested in having Tracy come out to your clinic because you know that you are due for survey soon, you can fill out this form and then she will come out and walk through the survey as if, she was the surveyor and tell you all of the things that maybe you need to address before your actual survey takes place. And one last tool that we have available is our emergency preparedness plan template. And so if you need help making an emergency preparedness plan for your CMS evidence binder, if you scroll about a third of the way down to the last link I just put in there, you'll see there's something that says evidence binder templates. And that leads you to a bunch of different template pages that are all of the different pieces you need for the emergency preparedness plan. That's another thing that your surveyor is going to be checking. So Yeah, pcrh@la.gov is one way to get in touch with us. Also, if you want a mock survey, or if you just have a question for Tracy, you can fill out the form and we'll make sure she gets in contact with you. I know probably everyone on this call already has her cell phone, but if in case you don't, feel free to contact us and we will make sure she is there to assist you.
And I don't mind that you text my cell either, by the way. That is often the quickest way to get in touch with me. But I wanted to make sure that everybody knew I don't have the la.gov anymore. So going through PCR, Eric or Amanda or PCRH at la.gov is a quick way of getting in touch with us.
And thank you, Holly, for that information about United Healthcare Medicaid. I'll make sure that Missy sees that in the chat as well. And we can try to see if there's anything we can do. Of course, it's a very complicated bureaucracy between our offices and the Medicaid office and the MCOs themselves. But that's important to know that United Healthcare does not seem to know the regulations for RHCs.
Oh, please follow up with me after this. Because I'm
Holly,
interested.
yeah, Holly,
Holly?
do you have a way of contacting Tracy? Do you know Tracy's phone number?
For those of you on here, it's 985-974-0086. I'm interested in what the specifics of that are, as far as if you're having a problem enrolling, or if it's what the problem is specifically, because sometimes we can get through that.
Yeah, Holly says she's going to give you a call.
Great. Also, if you have questions, sometimes we can, help along the way. Not, Medicaid gets real complicated with the MCOs and things like that. But enrollment and going through the RHC process and getting ready for survey and things like that, please let us know.
Alec, did you have a question?
Yeah, I wanted to mention a couple of things, but to kind of add on to the United Healthcare behavioral health setup, it is quite a task to get that done. Pretty much that survey consists of a lot of medical record reviews, just making sure that, all of the documentation is correct, and, just several other things, but it is a very difficult process. And it seems like a lot of the MCOs are kind of leaning toward that direction of having a separate contracting agency for behavioral health, which just is another hoop for RHCs to jump through. We've been fighting them on it constantly, but there's no budging. It's a completely separate department of United Healthcare, so that's why they're doing that.
That's a shame, because we all know that behavioral health side is so necessary.
Yep.
And CMS themselves are actually getting a little bit broader and more friendly to that behavioral health side. So it's concerning to hear that the MCOs seem to be not going in that direction.
Yeah, it seems like it's the way that it's set up, especially with Optum. I think a lot of it is that, there's a lot of behavioral health regulations that aren't included in the rural health regulations. So I think that's a big part of it. At least not referencing anything or adopting certain regulations. Seems like it'd be an easier process, but I think it's internally within the MCOs, just depending on how they have their credentialing and contracting set up. It seems that's what needs to be fixed, or some type of integration or communication between those departments would help.
Yeah.
I just wanted to mention a couple of things that we've been working on. We've had several RHCs that join on our monthly calls. So just to introduce myself, sorry, I own Collective Rural Healthcare Solutions. It's a consulting firm. I've been helping rural health clinics for the past decade, just open up and manage. But a few years ago, we set up a nonprofit organization to really specifically gear towards rural health clinics and start taking advantage of some of these grants and things that are out there. So we have been working on a couple main projects. My consulting firm had developed basically an online cloud-based portal for our clients to keep track of their compliance and just automate a lot of the regulatory aspects of running a rural health clinic. And we are donating all of that to the nonprofit, which we're going to be updating the portal tremendously. We're going to be rolling it out in sections depending. Right now, we're kind of footing the bill for it just to get it up and going. But we plan on, taking advantage of some grants to add some more features to it. But one of the things that we're going to, in fact, we have a meeting tomorrow if any RHCs want to join. And we're going to do a demonstration of it. But basically, it's an HR tool that completely automates the process for staff having to fill out a lot of repeating things, and that's one of the major hiccups that we find in all RHCs is that these personnel policies or personnel packets aren't fully completed, they're not done correctly, and a lot of them are just missing things. So we took very standard personnel packets that we use for all of our clients and put them into this portal. It's all through Microsoft, but basically the employee just has to fill out one online form. It takes in all their data, saves it in a database, and then the HR administrator can just print those forms out with all of the employees' information on it, where they could just review and sign it. There are some specific things, like if you have your own codes of conduct or your own job descriptions that you can upload, and it'll do the same thing with it. So there is a customizable feature to it, but it does help
Alec,
with.
would you want to put the link in the chat so so you can tell more about it on that tomorrow?
Yeah, sorry.
All right.
If you don't mind, I see one of my staff is on here. Can you go ahead and put the link for the meeting tomorrow?
And that way, they can access that.
Yeah, certainly.
Yeah.
But yeah, it's a great thing. And then we're also rolling out a lot of behavioral health stuff. So helping clinics, credential and get set up for behavioral health, some workflows, policies, procedures. So, all that's going to be available for free as we roll things out. So we're here helping RHCs too. So we'd love to be more supportive of this. It seems like you guys are doing a great job.
Thank you. Anybody else want to talk about what they're working on? That's awesome. That sounds really great, Alec. Let me see where we are. We're 7 minutes. Patty, Jeff, are y'all on? Any questions in the chat? Eric?
No, I don't think so. Sorry, I have my thing down.
Oh, I see Meta's question.
Yeah, Meta said, can we get a link to rules regarding CHW training requirements, billing intricacies, etc.? I did put the link for LaShawn. I'll put that back in the chat. As
And
far
there-
as the, yeah, I'm sorry, go ahead. Go ahead.
The CHW billing from Medicaid, I have to say, is pretty wide open. There's a guidance, but it does not get into specifics. It just is really basically what John presented as far as what the code is, and 1 to 2 patients is this much. It doesn't go into these are the required documents, documentation requirements or things like that. We are hoping to get to that point, but there's not that level of guidance from Medicaid yet. But we can certainly get. It's on Medicaid's website. All you have to do is put in CHW, and there's a Medicaid guidance from them. I don't know if Melissa's still, well, it wouldn't be Melissa, it would be Irma Gauthier that would help with the billing side for CHW. As far as closer to getting single source, I have no idea. To be quite honest with you, because I don't I don't know if Medicaid is going in that direction or not.
Tracy, I'm gonna try to put your PDF for the one that you did for Well Ahead 2 years ago.
Mm-hmm.
I got it on my computer, so let me see if I can get
Oh,
that.
perfect, perfect. Thank you, John. I would love to get a single source credentialing for Medicaid. I just don't know with everything going on. I don't know if they're working on that.
Yeah, Tracy, I'll just kind of echo what you're saying. I haven't heard anything about that specifically. And to your point, I think until we know what comes down from the federal government in terms of Medicaid, that will kind of determine, I think, what state Medicaid is gonna do, right? So we'll have to know if we end up with some sort of restructure of how Medicaid is funded from the federal level. And then the state will start determining what they're going to do. And so I can't imagine that they're doing anything, major right now with the level of uncertainty. I would say so, but I definitely made a note of it as we will be doing some Medicaid related advocacy in the coming session. I'm very, very sure. So we'll put it on our list and we'll just kind of have to see what the environment looks like when we get there.
And if behavioral health is becoming an additional issue, then that I think if you could add that to the issues priority list, because we all know the need is so much there. That needs to be something that's worked on to make it easier for RHCs.
And is that just for clarification, billing for behavioral
It's
health?
actually them. It sounds like it's and Holly, feel free to jump in here. It sounds like it's credentialing to be able to do behavioral health
Credentialing piece?
and to be able to bill for it. Sounds like they're making them go through another contract and another set of hoops when behavioral health is covered under RHC services. So why are they going through
In order to get
another
your
hoop to
RHC
get
rate?
their rate? Yes.
Okay, gotcha. Okay, so they're making you
Yeah.
do a bunch of extra steps. Is that, Holly, just the one? You did mention UHC, I think. Is it just the one that gave you trouble or just UHC? Okay, well
Anybody else? Are they having that within any others? Is it across the board or is it just UHC?
We're required, hey, this is Selena Gurley.
Mhm.
Optum is giving us, I'm having to go through almost an additional accreditation survey with Optum for our behavioral health, with a very significant 3-page list of things to jump through.
Okay.
So I think Optum is definitely the worst, but I can get a list and email it out on here in a second. But a lot of the other ones, it's just that they have a different contracting department for behavioral health. So basically, the clinic has to get set up as a facility to provide behavioral health services, and then go through that process. So it's not quite as in depth as Optum. They're the only ones that are requiring a full-on survey, but the other ones are still, they still have some hoops to jump through extra.
Okay. Optum and
yeah, Optum and
UHC.
UHC is what I heard. Okay. I'll look into that. I'm wondering if there's some regulation we can lean on to say that they need to not do that. And if not, we can push for something. So yeah,
I'm not hearing that in other states.
Yeah, let me
now.
put my email in the chat. If anyone wants to send me like more specific information on that, that'll help me in my like outreach and messaging on pushing back on this.
And Danae Cherie-Talion is over that group of MCOs. So that might be a good person to reach out to and see if we can have a meeting regarding that.
Yeah, I've been meaning to meet with her since she came into that role, and we just haven't been able to get to that.
Yeah.
with everything going on, we just
So
haven't been
much
able to
going
do-
on, yes.
So yeah, I think that might be a good topic to discuss for sure.
And I know now you put in an attachment, is that related to this part? The Optum issue and UHC?
Yes, ma'am.
Oh, okay. Okay, great. Did you have a question or something related to that?
No, I was
Okay.
just along the lines of they're making us do the same thing. The site survey, it's I've got like 6 pages of they're getting into clinical operations, quality management, documentation in our charting.
When you've already been through survey.
And
Yes,
that's
ma'am.
just for like kind of your run of the mill behavioral health services, or is it?
Yes.
Okay, so not like something special, like, oh, you're not doing like MAT, opioid use disorder, like anything. It's just kind of run of the mill, like that. That's bananas. Okay. Just for
For
counseling. Okay.
counseling. Okay.
Yeah, that's okay. That is, thank you.
That's
for sharing.
concerning.
I
And
had not
that's,
heard that. That's very concerning. All right.
yeah.
We will work on that.
And that's the point of all of this, is to get those issues and bring them to the forefront. Because if we don't know from y'all, we don't know. You know, so I really, really appreciate you not only attending, but giving us that feedback that we need to go forward. Is there any other suggestions for the March and April meetings that you would like to see? If you don't want to say it on here, feel free to contact me. And we're open. Y'all know you can call me at any time. You can email. I want to thank our speakers, Melissa Jacobs, John Bellamy, and Danae Hebert. Y'all did a fantastic job, and thank you so much for coming on today and participating in the RHC network meeting. Thank you.